Today I'm going to talk to you a little bit about our group, which you heard moved from the University of Washington to Washington State University. And although we do not have a PBRN yet, we have, in our work with primarily Native communities, created a number of, I think, pretty interesting networks of tribal partners and of Native researchers. So I'll be describing that effort. So the learning objectives, which I had to provide, are shown here, basically telling you about our program, things you know, like why do we conduct community-based research. I'll talk a little bit about some of the studies that we do and the kinds of study designs we use. And then I'll describe a very successful program that we've had over 20 years that trains Native people to do research in their own communities. And then briefly touch on some of our efforts, which are really very embryonic in starting a rural health network in Eastern Washington. So our group, which is known as iReach, moved from the University of Washington to Washington State University in 2015. Many people have asked me, after 30 years at the UW, why would you move? Well, WSU is a land-grant university, and they just started a medical school. They're in their second class now. So it really offered an opportunity to make change. Things weren't concretized. There was no right and wrong way of doing things, and they needed a research program to complement the medical school initiative. And I'll talk a little bit more about that later and their vision. We have for many decades now engaged with diverse communities and academic partners, basically in on-the-ground, real-world settings like you do, although we don't always work in clinics. In fact, oftentimes we are simply in the community. And we really want to focus on the strengths of the partners we work with. We also do community and population level training. We're a fairly big group. We have 15 faculty and 45 staff. We're in 3 locations. These are all locations where Washington State University has a campus. They actually have 5 campuses, and they have faculty members in every single county in the state, which is 39 counties. So they have a very distributed model. We have been fortunate to be successful in most of our grant efforts. We have about $30 million in grants right now. We've gotten quite a bit of funding over the years. We also have 6 center grants, all of which interact and are integrated to make it easier to work with our partners. So this is the current structure of our group. We work with many different colleges at the university, and that's by necessity almost, because they don't really have a large health sciences infrastructure or group. So we've ended up working with College of Pharmacy, College of Communication, Veterinary School. We just got a grant with the chairman of the Department of English. So it's kind of a unique environment to be working in, and there's a lot of cross-pollination of ideas. As you can see, we have 5 main units. We have a new unit, the Rural Health and Health Networks. It's run by a fellow named Justin Denny, who's a quantitative sociologist. We have a Native Hawaiian initiative, the Partnerships for Native Health, which is what I'll talk to you about today. And then we have a new Latino health initiative, and we have an addictions group. So this is a slide you probably have seen many times. I think it came from a paper by Larry Green. But to many of the people I talk to, they don't understand why are we doing community-based research. And of course, the answer is obvious, is that most of the health problems and symptoms are not seen in academic medical centers, which are represented on this slide by the tiny red dot in the corner. Most of the symptoms, most of the disability is in the community, and it's not even in primary care. As you can see, only 113 people out of every 1,000 with a problem ever go to see a primary care physician. So our work focuses, like many of yours does, on health inequities and health disparities. And I just thought it's always worthwhile to put up a definition when you talk about these concepts. One comes from Wikipedia, and the other from the Health Resources and Service Administration. What they have in common is they talk about gaps. They talk about health and healthcare, and they talk about these gaps as it pertains to specific groups, often racial, ethnic, cultural, socioeconomic groups, and that these differences are related to health outcomes. Another thing I just want to mention is that when you go into the community, we often, because we're working with underserved and racial and ethnic minorities, we often encounter a lot of distrust, at least at first, and people don't want to be involved in research. So one of the things we try to do is redefine research. And the definition that we most commonly use is that research is curiosity with a structure and a function, and that most of these groups have, in fact, been doing research for many, many, many millennia, because Indian people wouldn't know where to fish unless they'd done research. And the same goes for all the other ethnic groups that we work with. So this slide shows what I think is sort of the ultimate health disparity as an example. And it shows life expectancy in states within the continental U.S. and Alaska in which large numbers of Native people live, American Indians or Alaska Natives. And in each of these states, with a single exception of Oklahoma, the life expectancy for whites is 80 years of age or over. In Oklahoma, it's like 78. And you can see the life expectancy for Native people in the circles. And you can see that it's many years less than 80 years. And I'll draw your attention to South Dakota, which is a purple state there near the top. And in South Dakota, the average life expectancy is 68 years of age for a Native person. So that is about 13, 14 years less than the life expectancy for a white person. And on one of the reservations that we work on, the life expectancy for an Indian male is 50 years of age. Now, you all are familiar with the social determinants of health, but I think it's always worth reiterating the importance of these non-medical kinds of issues and their influence on health. And you all know that these kinds of things make up the predominance of the influences on an individual's health status. We try to capture some of these things in our studies. Of course, it's impossible to account for all of them, but I do think it's really important to at least give these kinds of influences thought when you interpret your results and when you go back to the community and try to act on the findings of your studies. But things like personal characteristics, which I think is sort of the most common sort of thing we attribute negative outcomes or behaviors to, but there's so many others: geography, physical environment, unfair policies, discrimination, that these are all really, really important and need to be thoughtfully addressed. So our work with communities, as I mentioned, falls into 4 sort of big areas. We've been working with American Indians and Alaska Native people for about 25 years because WSU is a land-grant university where we have a particular new focus on the 29 tribes in Washington, although our programs are nationwide. Native Hawaiians and Pacific Islanders is another group that we've worked with over the last 6 years. Surprisingly, Washington State has the 3rd largest population of Native Hawaiians and Pacific Islanders in the entire U.S. Rural populations, that's a new focus for us at iReach, and it was one that we were asked to take on to align with the new medical school. Our new medical school is focused solely on populating the state with physicians, particularly in rural areas. And you have to meet one of 4 criteria, you have to meet all of 4 criteria in order to get admitted. They take no out-of-state students unless they have parents or other strong ties to Washington State. So they're focused on the state. And so this new initiative fits well with the mission of populating the areas that do not have health care and clinicians. And as you'll see, we have many rural and underserved counties in Washington State. And then Latinos and Hispanics, whatever your preference is. Again, this is a new initiative that we've taken on in the last couple of years. And our state, because it's so agricultural, is projected to be a majority-minority state by 2050, and most of that minority is going to be Latinos. So now I'll turn a little bit to talk about this one program, Partnerships for Native Health, which is the one that's been in existence for the longest period of time. It's sort of a prototype for this new development of programs at WSU. We have worked with urban and rural populations. We've worked across the lifespan. We do all kinds of research, physical and mental health, disease prevention, health services, health literacy, and that's because we have a population focus and not a disease focus. Again, our emphasis is on achieving health equity. We do lots of community outreach, community engagement. We do training and education. And speaking of networks, they're not an official network, but we have worked with about 160 partners that include everything from tribal colleges to health departments to Native organizations to universities and so on. In terms of how do we actually reach out to these communities? Well, I think that's a whole other talk, but just to mention a few things. First of all, we have 2 tribal liaisons. These are people, all they do is outreach and engage populations. They go places, they give talks, they're at health fairs, they show up. We make all kinds of culturally appropriate posters and brochures and public radio announcements. We provide training and education to the people that we hire on the ground, and we go to community events. Powwows is a typical example, but there's many others. How do we engage people? How do we engage our partners? Well, first of all, we hire American Indian, Alaska Native, Native Hawaiian, Pacific Islander, and other minorities. So about half of our staff is minority. We educate our partners about the sponsors. We discuss the funding announcements and tell them what we can and can't do under a particular announcement. We do what we call translational research, but it's community-driven translational research, and we turn their service needs and questions into actual research questions. It's important to find points of mutual interest and intersections, and I'll describe an elders event that we just did a couple weeks ago. And incorporating their ideas and interests, even if it's not yours. And then finally, just leveraging community opportunities, events, and figuring out what is the research angle here that is a win-win for both parties. So these are just some of the topics that we do research on. I'll talk some more about individual studies in a moment here. But everything from substance abuse, behavioral health, homelessness, high blood pressure, diabetes, cardiovascular disease, cancer, and most recently we've been doing a lot of work on cognitive impairment and Alzheimer's. So a couple of examples of our projects are here. The ones in red are the ones I'll talk a little bit more about in the following slides, but these are just some examples of the kinds of predominantly NIH-funded work that we've conducted over the past 20-plus years. So you can see it ranges from, the genetics of smoking, enhancing cervical cancer prevention. We do some epidemiologic studies, for example, on cardiovascular disease, because nothing was known about that, cerebrovascular disease, because there was no information at all on Native populations. We do mostly interventions at this point because we believe that the time for describing things is pretty much over unless it's something we really don't know anything about. So we've done a family-based intervention to reduce stroke risk. We use text messaging in several of our studies and digital stories as points of intervention. And just a few more, again, the ones in red I'll talk about. We use something called contingency management, which is an incentive-based intervention for behavioral health problems. We have 2 grants on suicide prevention in urban and rural populations. We've looked at biobanking and what does the All of Us program mean for Indian people. We've done traditional diets, a modified DASH diet, to reduce blood pressure and to improve control. And then some studies with young children on attachment theory. And then, as I mentioned, we've most recently launched a big effort on Alzheimer's. So this is an example of one of the studies. It was done in South Dakota and in Arizona with tribal members. And one of the things that we wanted to better understand is why is there this enormous discrepancy in the prevalence of smoking in the Northern Plains and the Southwest. It's about 70% men and women being equal in the Northern Plains, and it's about 20% in the Southwest. Has nothing to do with the availability of nicotine replacement therapy or smoking cessation programs. So basically, we looked at the cytochrome P450 system and the nicotine pathway, which breaks down nicotine and other toxins in cigarettes. And what we found was that there's a substantially higher metabolism in the Northern Plains group, the one that has the high smoking prevalence. So that makes sense. That's why they smoke more cigarettes, because they're breaking down the nicotine much more rapidly. So you might think this is an esoteric finding, except that it has public health implications in that in the Northern Plains, you want to keep people from initiating smoking, where in the Southwest, you could probably also have cessation programs, where in the Northern Plains, that they don't seem to work very well. So it alters your public health strategy. This is a study we had on cervical cancer prevention. You all know that cervical cancer is caused by human papillomavirus. And in the Northern Plains and in one area in the Southwest where we did this study, it's very difficult to get in to see a healthcare provider, and there's lots of remote areas where people live. So we enrolled over 1,000 women in these 2 areas, and they self-sampled vaginal swabs for HPV, looking for high-risk subtypes, and also what were the correlates of having these high-risk subtypes. You might say, where did you do this? Well, we went to powwows, community fairs. The women went in the bathrooms and brought out a swab. So what did we find? Well, women really liked doing this. They said it was easy, the samples are easy to collect. 60% preferred going in a bathroom in a powwow to going to see a clinician. 20% were positive for high-risk HPV, but the profile was different. There was a high prevalence of genotype 51, which is not that common in white women, and it's not that well covered by at least the early vaccines. The high-risk subtype peaked in the age group late 20s, and it was associated with women who did not get pap smears. So this is a promising strategy to engage women in rural settings, especially those at high risk. And the really interesting thing, when I started wondering, what about this unusual profile? So I went back and I talked to the people who did the trials on the vaccine. There was not a single Native woman in any of the trials. So another study we did was on cerebrovascular disease. Again, there's no data on cerebrovascular disease in American Indians before maybe 7 or 8 years ago. At that time, some researchers with the Strong Heart Study, which is a large epidemiologic study, looked at stroke incidence, found that American Indians have the highest stroke incidence of any racial or ethnic group, even higher than Black Americans. So we wanted to go and look at what is the prevalence and the associations of covert disease, what people call subclinical disease, which can be detected on MRI. So this was a massive study. We had 13 IRBs with universities, tribes, area Indian Health Service. We had over 1,000 participants from 12 tribes in 3 states. And these people completed a 3-hour battery that included an MRI, sometimes was a 3-hour trip to the facility. They did a neuropsychological test battery. They did surveys, gave blood, and had a physical exam. So what we found is shown briefly on this slide. There is a high prevalence of covert cerebrovascular disease defined as infarcts on an MRI. So these are not lacunar infarcts, which are typically smaller. And males and females had about the same prevalence. And as you would see in the majority population, the prevalence goes up with age. The really interesting thing that we found was when we looked at the neuropsychological test battery that we did, because, of course, this covert cerebrovascular disease, one of the manifestations is impairment of your cognitive abilities. So the test scores may not mean very much to you, but the important thing is that in this population, every single test score was shifted to the left. So why is that? There's many explanations. One of them might be that American Indians are more cognitively impaired as a population. Another one might be that the tests don't work. So we carefully looked at the tests that we were using, which were those recommended by the Alzheimer's Disease Research Centers and the Alzheimer's Association. And these are just a few of the tests. And you can see that someone living on the Fort Peck Reservation in northeastern Montana, 5.5 hours from an airport, might not do well on tests that have you remember rhinoceri and camels, and might not do that well on measures of abstract thinking that have no relation to their everyday life. So we believe that these tests don't function well in this population. So after we did our study on cerebrovascular disease, people in these communities started becoming really aware of stroke and cerebrovascular disease and the impact that they, for the first time, really recognized that this condition was having on their communities. So they said, well, we need to do something about this. So we went back to those 12 communities, and we designed a study called the Family Intervention in the Spirit of Motivational Interviewing, which is basically a culturally adapted, home-based intervention where a facilitator would go into the home and basically do point-of-care results, give point-of-care results to all participants ages 11 and older on smoking and glucose and blood pressure, and then gave them sort of a card with, red, orange, and green in terms of their risk. We just finished that study, and I can't tell you the results, but what I can tell you is that The grant provided for enrolling 280 families, and when we were getting close to 280 families, the community said to us, we have so many more families that we need to enroll. So we ended up enrolling 80 more families, well above what we were funded to do. So we are hoping that this intervention has a positive effect. We haven't finished all of the 6-month follow-up, but we're close. Another study was on colorectal cancer screening. Alaska Natives have the world's highest incidence of colorectal cancer, 9 times as high as some other populations, and they have very high mortality. So we conducted a randomized controlled trial of text messaging to increase screening. We worked with a tribally owned healthcare organization that was based in Anchorage, but that had enrollees in 60 small villages outside of Anchorage. And we enrolled people from 40 to 75. They screened people at age 40 because of the morbidity and mortality associated with colorectal cancer in this group. And they received either 3 texts 1 month apart or their usual care. And we looked at the medical records at 3 and 6 months because it was basically an HMO, so we could see if they actually got screened, whether they had colonoscopy or FOBT or FIT. And what we found is the intervention increased screening by 42% versus usual care in the older age group and by 24% in the younger age group. So they're now thinking about how to use text messaging for other health conditions because it's a very cost-effective, it's very a simple way to reduce morbidity and mortality. Another study we did is on maternal and child health. Here we again conducted a randomized controlled trial of an intervention called Promoting First Relationships, which is an evidence-based intervention in non-native populations. We culturally adapted it, and the aim was to increase attachment between parents or caregivers. There's many caregivers in Native communities, so that was one adaptation, with infants or small children. And this intervention has been shown to reduce downstream negative or adverse outcomes like suicide and violence, school dropout, and so on. So we implemented this intervention on 3 reservations. We enrolled young children and their parents and the caregivers. And then we trained local people to be the interventionists and the community educators. The way this intervention works is it uses videos of the families, and then the families, the caregivers, are given immediate feedback, and it's discussed over and over 12 sessions. And there's never any punitive aspect to it. It's all very sort of positive and strength-based. And we have the results back from one of the 3 sites. It significantly increased the attachment between the child and the parent. And one of those sites is now working with the WIC program to incorporate this into the WIC program so that every new parent can be exposed to this intervention. And then Alzheimer's disease. I gave a little bit of information. Again, this initiative is both national, but our main initiative is in Washington State. There's about 100,000 cases, not Native people, about 100,000 cases in Washington State. And they expect a 40% increase by 2025. So our state is just like every other state. It's the big train coming down the tracks that nobody's ready for. Washington, it's the 3rd leading cause of death. And there's been an 82% increase since 2000, and that's the 3rd highest in the U.S. So our state has a large burden of Alzheimer's. And we aren't even a state where retirees migrate to. there's absolutely nothing known about Native elders in Washington State. So one of our missions is to try to understand more fully what the population burden is. So in the United States, however, there are close to 500,000 American Indian elders age 65 and older. Now, Native people consider elders 55 and older. So this number, from their perspective, would be low. And that number is expected to triple by 2070 or so. American Indians and Alaska Natives have a lot of risk factors for Alzheimer's, like poor educational attainment, poor quality of the education, rurality, poverty, and then all the clinical factors like hypertension and vascular injury and obesity, diabetes, head trauma, and so on. And then on top of that, they have a very fragmented and underfunded healthcare system that comprises 34 urban Indian health organizations scattered throughout cities in the United States, and then the tribal network represented by the Indian Health Service. So as I mentioned, some of our efforts now are in trying to understand what the burden is and helping providers in Washington State anyway who serve Native individuals become more aware of cognitive impairment and help them with some of the skills to detect it and to manage it. So one of the things we've done is create culturally tailored materials like the brochure in the upper left, upper right there. We also give talks at tribal clinics. The map shows several sites around Washington State that have tribally run clinics or healthcare centers. And so we've been traveling around the state, giving a presentation that provides as much information as is available on Native populations, as well as just general clinical information. We just finished a training with primary care providers on detection and management of mild cognitive impairment and Alzheimer's disease. And during that training, we had about 15 Native providers, and they culturally adapted the standard training that we had presented. So now we have one that will be able to actually implement, and that will have all the adaptations made. We also host events that incorporate screening for cognitive impairment. And the purpose of these screenings is really to understand, again, what the population level or the population level burden of cognitive impairment and Alzheimer's or dementia might be among American Indian and Alaska Native elders. And just as an example of how we try to engage around events that are occurring, I was out at the Yakima Reservation, which is a big reservation in Washington State, and talking to the Agency on Aging, and they said, well, you know, we might lose our funding because we don't have enough on Alzheimer's. I said, well, you know, maybe we can work with you on that. And we worked with them over a couple of months, and we ended up going to this lunch that they do every year for their elders to honor their elders, and they actually have older American Indians from around the state come, not just from their own tribe. They have about 800 people show up for a lunch. So we went out there in our van with 11 people, and we screened 630 people in 6 hours with the ascertained dementia 8 and the mini-cog. And now we're going back and we're presenting the results to the tribes in that area, because about 40% of people screened with either significant impairment or needing further evaluation. So this is beginning to give them an idea of what the burden is, and that they probably need to train their primary care physicians, who will be the ones detecting and managing these individuals. And then we were invited to partner with the National Indian Council on Aging. That's a national organization for elders, and they have a biennial meeting, which is going to be in September. And they have 1,500 elders. So they've asked us to come and basically do the same thing and give a talk. So, you know, this is just an example of how you leverage these events and sort of do this community-based translational research. And now I'm going to talk a little bit about a program that we have that trains American Indian and Alaska Native people to do research in their own communities. And I think in many instances, research and education are these two silos that don't really interact a lot. And I think this program is an example of how you link education with research, and then how do you build that out into a community. So this is just a standard educational pipeline. Our work is basically on the bottom half of that. We run several career development programs, and then we encourage and support the people, the graduates, even after they leave the program in their efforts to get grants and to achieve leadership positions and mentor others. So the program is called the Native Investigator Program. Everyone in the program is American Indian or Alaska Native. It's a distributed model because in no place in the United States are there enough Native faculty members to actually run a program. So they stay at their home institution. They come in 3 times a year. They're assigned mentors. They have homework every week. And they get really intensive mentoring by an interdisciplinary faculty over a 2-year period of time. That's how long the program is. So far, we've had 48 doctoral level trainees from 36 tribes in 10 cohorts, so it's a 20-year program. We've kept 86% of them over their 2-year cycle. 19 are now tenured or in process to become tenured. So that's almost half. They've gotten $120 million in grants, and they have published 450 papers. Most of those filling gaps on things we didn't know about for these populations. So for us, more importantly than giving you all those statistics or giving you the 450 papers, is what has this created? And this has created a network of collaborators across the United States. This is a social network analysis, which you're probably familiar with. It's basically looking at all the manuscripts that our graduates have written and who else is on those papers. And as you can see, across 20 years of the training program, there are people from all the different cohorts working together. The darkest lines are the main people in the program who don't change. But we've created a network across geography, across tribal backgrounds, across types of institutions, of researchers, all of whom are committed and passionate about a single vision, which is to improve Native health. And I have one of these for grants, obviously. The lines aren't as dense because people don't write as many grants, but it's the same theme. It's created a network of collaborators. Then the next thing that we did is we asked 7 of these individuals to become satellite centers because Native populations are strewn about. They're not in neighborhoods. They're not in one single place. They're often in hard-to-reach places. And if we wanted to disseminate our ideas or if we wanted to do small sort of pilot studies in various areas, there was no way to do that. So we asked graduates of our program to, with our help and with grant funding, to set up these satellite centers in areas where many Native individuals live, either in urban or rural settings. And you can see there's one in the Pacific Northwest, there's one in Minnesota, there's one in Denver, there's one in Oklahoma, There's one in the southeast, and there's one in the southwest, and also one in Alaska. So we've covered most of the areas where Native individuals live. So now I will turn for a minute to talk about our Rural and Underserved initiative. Washington is a rural state. It's also an underserved state. And as you can see on the green map there, 21 of our 39 counties are rural. So a large part of the state is rural, and only 8 counties in Washington have no medically underserved populations or areas. So especially in the center of the state, there are a lot of underserved areas. So what we call our Washington Rural Health Initiative, you can see on this map the proportion of deaths from the most preventable causes in Washington state over the 5 years from 2011 to 2015. The green areas are the good areas, and the orange and red are the bad areas. So there's many more preventable deaths in those areas. You can see the orange and the red tend to be in sort of the northern and central part of the state. There is that big green blob there in the middle. Well, that's a vacation area. That's Lake Chelan. So that's why there's better health care there. But there are many, many areas in the state where the proportion of deaths from preventable causes are certainly amenable to intervention. So as you know, I'm sort of preaching to the choir here, rural residents have many health disparities, just like our American Indian, Alaska Native populations. And they have higher death rates for the top 10 causes of death. And these disparities have substantial social and economic consequences, including impaired productivity and consumption of healthcare resources. And as you know from your PBRNs, many of these providers are isolated. So our project proposes to use DARTnet, which I'm sure most of you are familiar with, to link the health records of primary care practices around the state to create a research, clinical, and educational network. Again, with our new medical school, this is a really golden opportunity for us to merge all of these kinds of important needs. Like you, we want to use the data to examine health conditions by a number of factors. Again, our issues are how to resolve health disparities. We also want to engage these practices as training sites. We have other health profession students on the Spokane campus that are interested in these sites. We want to link the providers with the academics in the new medical school. And our goal is to try to bring on board 20 sites in the next 1 to 2 years. The Washington Rural Health Initiative is going to capitalize on the 39 clinical sites that have already signed a memorandum of agreement with the Elson S. Floyd College of Medicine. So they have the school has a very active group of 3 people who go all over the state and try to engage practices. These are the ones they've engaged. I think there's 4 more that are ready to sign on the dotted line. So we have a bit of a ready-made set of sites that we can try to engage in a PBRN. I'm sure all of you know about DARTnet. I work with a faculty member who's a quantitative sociologist who has experience linking electronic health records in Texas. And he actually examined a number of different options, and he decided that Wilson Pace's DARTnet was by far the best tool. And so we are in the process of trying to work through some of the details of how we might engage these sites and how we might get them to work with us through the DARTnet technology. So I thought I would end with a couple of slides about sort of operating a community-based program within an academic institution. There are a lot of benefits to the university. We're the second largest research unit there now after shock physics, which gets a lot of money from the Department of Defense. Our programs align perfectly with those of the medical school. As I mentioned, it is focused on rural health care, and it's focused on diversity and disparities. It also aligns with the land grant mission of the school. The motto of Washington State University is to serve the people. They are not interested in being a biomedical complex. Their mission really is to serve the people of Washington State. Health equity, we bring this unique and dynamic platform, and it's a high-profile one at WSU to address a wide range of health conditions in diverse populations. And several of my faculty have really attained some leadership positions because of this initiative and its visibility. So that's been really nice. So the impact, does this make a difference? Health status, we have made a difference on the health status, I think, of some of the communities that we're working with. I showed you some examples. One of our big concerns is that they're sustainable. And so now we are partnering with the Department of Economics, and they are actually bringing together health economists, and 8 of our projects now have health economists as part of the research team to figure out whether or not a particular intervention that works is sustainable, and if so, how. I think a program like ours has wide appeal. The topic, community health, population health, resonates with all kinds of different people in different disciplines and colleges. So it's pretty easy to find collaborators. And I think because we're new, and this was one of the reasons I moved from University of Washington, is that there was an opportunity for culture change. And I do believe that we have changed, or perhaps started to change, the culture. Their traditional land grant focus on agriculture and veterinary medicine is starting to change, and it's being incorporated with the concepts of human health. Washington State University is the #1 university for USDA money, so they're not research poor. They simply don't do health research and haven't done much of it until we came over. But their new initiative, something called the Drive to 25, the logo is Seeds to Cells. So they're clearly taking up this idea of health and health at the community level. And then finally, what are the future needs and the goals of a program like ours? Like, what would I change? Well, probably like many of you, the fiscal and administrative structures are very difficult to deal with when you do community-based research like we do. We need our structures to be more nimble. We need administrative and fiscal people to understand that we need logos made by local artists and we need to pay them. And those are just minor examples, but they're ones that are important to communities. We need flexible human resource processes. We often need to hire and pay people in different ways. We have different ways of handling engagement in research, and so we need the HR processes to be able to handle those. I think we also need to have a centralized methods and design support process. As more and more people engage in this kind of research, they need to be able to learn the skills or have people who are already doing this advise them on how their studies need to change and what study designs are acceptable and which ones are not. As you all probably know, sometimes randomized controlled trials are not acceptable. And you need to do weight control, or you need to give both arms something. So these kinds of things need to be considered, and there has to be a venue, a place for people to come and to get expert advice. And then finally, what are some of our goals for this new Spokane Health Sciences campus? We want some new buildings that engage the community, that are community friendly, that have themes of Native Hawaiians or Pacific Islanders or tribal people, things that bring community to a physical space. Some of the issues around education and Native people have to do with there are no cohorts of Native kids in school. What if they had a dormitory? What if they could engage with each other? So we're working on that. We really are focused on meaningful and bidirectional relationships with the regional tribes. We want to do more of that. We want to increase the diversity at all levels at Washington State University. The new president is doing well, but the campuses are in areas that are traditionally white and dominant culture. So it requires a major, thoughtful effort to increase diversity. And then, like all of us, we'd like more integration across colleges and disciplines, across people working together with the same commitment and passion and vision. Thank you.
If you're not at a land-grant university, and if you're in a structure, we struggle in Alberta. Like, there's been a large Truth and Reconciliation Commission going on in Canada around the legacy of residential schools and survivorship and challenges with institutionalized racism for First Nations in Canada. And so we're all kind of on this journey and sort of stumbling our way. But what you're also doing here is we also have a lack of knowledge around the importance of participatory community-based research. You know, it's very much a biomedical kind of institution. So do you have a sense, or could you give advice in terms of how you started to break down some of those pillars? I mean, part of it was, okay, well, let's build a new school. But if you weren't going to do that, how would you start to have those dialogues to illustrate the points? To get some system change around where dollars are going and efforts are going.
Yeah, at the level of the university, is that what you're asking?
Yeah, at the level of the university.
Well, that's a difficult question. You know, when we were at the University of Washington, we were entirely on soft money. The whole kit and caboodle was soft money. You know, so if you're bringing in the money, you know, there's not a whole lot they can say. I mean, they can make things more difficult with fiscal management and HR and things like that. So what we tried to do was to become as independent as possible. So that, for example, we have a total shadow system for everything. So we have a shadow system for HR, we have a shadow system for all of our purchasing, we have a shadow system for all of our grant work. We put out all of our own grants with our own people. You know, we have to get the final approvals, but we basically developed a shadow system so that we could operate in the way that we needed to operate. So I don't know if that answers your question. It's very hard sometimes to work within the structure of a large biomedical institution like the University of Washington. And at that time, they still don't really value community-based research. We were, the largest group, and one of maybe 2 or 3 that really had programs. So it's hard to operate in an environment like that. I would just say become as independent as you can so that you control where the resources go and how things are done. That's one way.
Well, thank you very much.
I'm impressed that you work with 29 different tribes. I'm from New Mexico. We only have 21, which are totally independent nations. My question is, context is everything. If you have one project that you're working on with different tribes, how do you address the different cultural context between tribes on one project?
Well, I will just say we don't work with all 29 in the same way. So we have levels of partnership. So we have levels that we would call like informal or educational. They might just get a newsletter or something like that. And then we have partnerships where we actually do training, or we like go in and do an Alzheimer's training for the providers. And then we have research partnerships where we hire people and we send them money. So that there's different levels. So I wouldn't say that we have, the kind of partnership you might be thinking about with all those 29 tribes. So, it's a great question because it's the age-old argument about pan-Indian versus culturally specific. And I don't have a good answer, but what we try to do is, like as an example in that project on HPV, we had different sites. So we developed a really low literacy, simple, fact-based brochure, and we took it to the various sites. And there were virtually no changes except for what we call the cosmetics, the pictures, the colors. So that's one way to do it. And honestly, we try to have conversations around this, and we say, we can't tailor an intervention or a brochure or a digital story 29 different ways. So how do we do that? And surprisingly, we have found that simple, plain language is the key. So in our text messaging interventions, we did focus groups in many sites. And the text messages basically stayed the same. They don't want text speak. They don't want a lot of cultural stuff in there. They want the facts. You might change the fact if you're in Alaska versus the Northern Plains or the Southwest or Montana, in terms of smoking prevalence or something like that. But one of the things I think that just has come out over and over again is plain English, simple concepts, things about people, communication, family. Sometimes we have to adapt things. And in those instances, we use sort of a toolkit model where we break things down into modules, and you can change this module, but maybe you can't change that one so much because that's the active ingredient.